Hello, everyone. Thank you for joining the Center for Learning Health System Sciences for our special edition of the iMpact seminar today, November 1st with Dr. David Dorr. Before we get started, I'd like to cover a few expectations. So today's seminar is being recorded. The public slide deck will also be made available on our website under the Education tab, and I'll put a link in the chat for that as well. Following the presentation, we invite you to raise your hand or type questions into the Q&A in the Zoom. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, our next iMpact seminar will take place on Tuesday, December 6th, with Dr. Rohit Ramaswamy of the University of North Carolina presenting Learning Through Spread, evaluating community health improvement initiatives in 20 communities in the US. In addition, I'd like to highlight that we have our first Clinical AI Trials Journal Club happening today at 1:00 p.m. Central Time, so right after this webinar. And they will be discussing the article, Randomized Clinical Trials of Machine Learning Interventions in Healthcare. So I'll also put that link into the chat if you're able to join as well. And with that, I will turn it over to Dr. Genevieve Melton-Mukes to introduce our speaker.
Thanks, Lindsay, and thank you to everyone for being here. Thank you, David, for being here with us today. I'm thrilled to be able to introduce you. David Dorr, Dr. David Dorr joins us from Oregon Health and Sciences University. He's an internal medicine physician and informatician, serving as professor with joint appointments in both departments. He's also OHSU's Chief Research Information Officer. David's work as CRIO focuses on improving the capabilities and use of innovations to manage data, information, knowledge in research, and to translate that into improving care for our patients. His work has really been, and what I think he's most known for is his work around collaborative care and chronic disease management, really thinking about the transformation for how we can better give population health to people that we serve. His work really intersects as well with quality clinical information systems and how to optimize them to support this type of care transformation, and in particular, the care of elderly patients and specifically people with chronic diseases, and how that impacts patient safety, in particular around longitudinal care management, to be able to track those patients, their needs and goals. So really excited to hear from him today, and please join me in welcoming him. Thanks, David.
Thanks so much, Genevieve. I love that bio. I'm going to steal part of it. It was wonderful, and it's a pleasure to be here. I'm going to start sharing my screen for the talk because I took a little from both worlds. I will tell you a little bit about Care Management Plus, which is the effort, my research team in essence, where we focus on collaborative care models, especially for our most vulnerable populations. What I'm really interested in discussing, I think, with you all today is about how we can really accelerate the adoption of learning health system capabilities through data, and really accommodate the complexity of our healthcare systems in order to better meet the needs of people who are particularly vulnerable. And so that has an overlap between my Chief Research Information Officer role as well as my research role. And so I will actually divide it up that way. So I will talk about shared governance as the CRIO part, and then move to some ideas around pragmatic trials that we've been engaged on that I am trying to use a catalyst for. So at OHSU, I wouldn't say we have a particularly advanced learning health system effort. We do have some really strong points, a wonderful educational program funded through HRQ, and we have done a number of learning health system related efforts, but we've really been looking at how do we, where do we embed a home for innovation within the larger systems, within our health system, within the research systems, and within our education. And my point here in the underview, rather than an overview, is that IT and informatics can be a really effective substrate for this innovation, can be a wonderful home. But one of the big problems in many health systems is that just keeping the electronic health record system running and dealing with the many updates we get is really difficult because information technology groups, of course, have to deliver service, right? We have to keep things going and make them work. And so, how do you fit innovation into that, where you're trying to do more rigorous evaluations? I'm using pragmatic trials as an example here, because we've studied a number of them through the NIH and NIA collaboratory work. Specifically, I've been doing because they require these data, and the interventions need to go through our electronic health record systems in many cases, and we often end up with this difficult problem of workflow, where we're touching clinical workflow, and how do we want to improve it, but how do we study it, improve it, and then sort of sustain it. So really what I'm going to try and present to you are some ideas about overcoming these dilemmas in a couple ways. So why am I so interested in these issues? It really started in Intermountain Healthcare at the turn of the century, where we built a program called Care Management Plus. And the goal of Care Management Plus were to take particularly vulnerable patients, people with advanced illness, people with multiple or complex chronic illnesses, the frail elderly, people who have functional loss, and also have issues around social complexity and behavioral needs, and try and build systems that better cared for them. And we do this through this sort of three-step process. We build better systems to identify them when they're particularly vulnerable, and try and figure out how we can tailor care to those needs, and then improve the outcomes through pragmatic trials. And we've shown through this program that we can, through Care Management Plus, that through care coordination and IT systems, improve their care through a variety of techniques. But really, this tailoring care can be challenging in the context of our everyday lives in the healthcare system. So I wanted to build more capabilities to have these innovative opportunities available to more researchers. And so at OHSU, we had the idea of having a chief research information officer for quite a while, but we hadn't really sort of launched it in a robust way. So through some support from our leadership, I helped to define this role, and then they asked me to serve in it. And in this role, I provide leadership, so really trying to understand where things are going from research broadly, but really especially clinical and translational research and learning organization constructs. I try to facilitate innovation and then also improve the services that we offer through it. And we have a big strategic initiative that has driven a lot of this change recently, and we've been starting to see some great improvements. But one of the big challenges we've had is how to govern these efforts. And so this is the OHSU governance. It's publicly available on their website. You could see that really the health system is separate from research. And we have this top executive leadership team committee is really the only place where they all meet together, and it's really to deal with pressing high-level issues. Sorry, that's a little bit bigger but you could see how far apart the health system and the research are on the component. And you know, many learning organizations try to bring together some of the rigor from research into the health system, constant desire to thrive and improve the care we deliver. And so the question is, how do we do that? And for us, interestingly, our information technology group, we had the best opportunity to bring those missions together, since everything was sort of separated. And so in our efforts, we really touched so much in terms of innovation, education, the academic departments, and some shared resources. And at the top here, we built an informatics governance group and a research data governance group that really facilitates some of these concepts. So in our informatics governance group, which I convene, the CIO, our CHIO, our Chief Health Information Officer, and then cross-mission representatives sit on that, and we literally plan our cross-mission strategy for addressing the needs of the university broadly. Yes, they also help us do our work, but they're all driven literally by how do we really help the university to thrive. And it's one of the few places where we have the opportunity to do this. You know, it's not perfect, but what I will talk about in pragmatic trials is literally driven by this group saying, oh, we have some opportunities here. How do we act on them? We also deal with research data governance, which does feed into a overall data governance committee. And we deal with how do we make more data more findable, accessible, interoperable, and reusable. And then we drive that back into the health system as well, since data adequacy is such a big issue for so many of our trials. So that's been a lot of fun, actually, to build this up. And I would say, you know, these are great places to think about change if we can do it. And really, I've taken an approach where we have tried to figure out how do we enhance these capabilities without a center or you know, a designated even committee to work on learning organization constructs. So we do this joint strategic planning where we can, and we do bring people together beyond this, other stakeholders throughout the system. We also use change agents. So we funded a research data concierge through our strategic initiative and through our CTSA, our Clinical and Translational Science Awardee Institute, called Oak Tree. But the research data concierge actually has the mission that you see on the screen, where they deal with clinical needs. They spend a lot of their time basically trying to figure out how do we support quality improvement efforts? How do we make all data easier for all the people who want to improve what we do, not just generate knowledge in an efficacy trial? And then helps to bring that together earlier. So she's been a massive help for us. And a lot of our work is relationships. So building up those relationships and trying to find opportunities to improve. Now, one of the things, and I do like this slide, we've been trying to work on is, if we think about learning health system definitions, we have sort of simpler versions, I think, from this National Academy of Medicine report, where it's just sort of this cycle, the virtuous cycle of where we're, you know, taking data and we're, you know, putting it together, analyzing it, interpreting it, and then changing, right? And that's sort of a very simple version of this, to what I consider the sort of research model, which I built when I came onto my project, where we really have all these components built into it that are intended to drive knowledge in addition to improve overall. And most of the time we're in the middle, if I'm honest. We can't do everything in terms of a full research, and we need to really think about how we can make this work in care. And the other thing that I think is important is that a learning organization doesn't operate sort of on its own. And this slide's from HL7, which is going to give away my hand in the talk a little bit here. Where it's really, you know, knowledge is being generated all the time. This can be put, you know, sort of synthesized into guidelines, or systematic reviews, and then that can go into various ways, various recommendations that then can be put into clinical decision support. And then we can, sort of have this more global learning ecosystem where we're constantly surveilling our analytics and reporting across broader efforts to try and drive more rapid global knowledge and global change, and then apply it back to our system. So we can't forget that. And I think everybody with the pandemic is aware of how important this is to do, and how much we need to enact this, sort of be part of these systems. So when I think about really trying to drive change, generate knowledge, and feed it into these broader systems, I think about pragmatic trials, especially pragmatic randomized controlled trials. And a pragmatic trial, which I'm sure you know, is one that's intended to be able to be implemented into routine care settings without a lot of extra effort. And so the PRECI2 diagram here is sort of highlights some of the aspects of the pragmatic trials, which I'll describe a few. So eligibility is supposed to be who you treat for these conditions now, who you see, who could benefit, even if there's some complexity embedded in them. So not, trying to narrow the population down to the ones most likely to benefit, but really people you see in routine care. And that you need to have a lot of flexibility in how adherence is expected and measured and how you deliver it. There has to be adaptation. That's part of this, so it can work in care. You have to think about how much it can impact the overall organization, and really try and make it so that it's sustainable beyond the trial. And we have found in some of our efforts that informatics is obviously very important in learning health systems, but also that in my work with the NIH Collaboratory, that we really see these pragmatic trials as driving a key aspect of a learning health system. So on the left here is a competency assessment for the kinds of things people need to know as they're learning how to interact and build learning health systems. And as a component of that, the informatics component, I show you Rachel Richardson and Keith Marcello here, who at the NIH Collaboratory sort of drive the electronic health records component of it, and focus a lot on how do we embed these pragmatic trials into routine care, into our EHRs. So such an important aspect of it. And then we, Julie Bynum and I and others, have been working within the there's lots of collaboratories, but we've been working on the National Institutes of Aging Collaboratory. And what we found is really so many of the capabilities we need to drive these trials in our systems and show their benefit are dependent on the informatics capability, how you can manage your data, your information, how you can organize your knowledge from design. And ours is actually focused on Alzheimer's disease and related dementia. So the whole collaboratory is focused on that group and their care partners. And I'll tell you that these cohort definitions in Alzheimer's disease is incredibly difficult. It's underdiagnosed, it's actually misdiagnosed frequently. And so data and computable phenotypes are so crucial, but then also how you implement it in care is crucial, because when you're trying to run a pragmatic trial, you have to have the ability both to put it into routine care, but recognize that your population health approaches are going to be incorrect in many cases. So your intervention may misidentify or miss people. And when you are working with people with dementia or potentially have dementia, that's a huge deal. As well, sort of their ability to participate is a little different. So it's a particularly challenging one. And we found that really that identification, the screening, the monitoring, all of this requires really delicate approaches to how we interact with the EHR and drive our efforts. So we've been working really hard on trying to understand how we build these capabilities overall. And I've come to this conclusion that we really need a catalyst, that the EHRs have some capability to do this, but really to drive this into workflow, especially when there's so much nuance, we need something. And we've really focused on fast healthcare interoperability resources as a catalyst, a challenging catalyst, a catalyst that's doesn't have a lot of the components we need, but one that we think will be very helpful in what we're doing. So, FHIR is just a messaging standard. It's just a way to define the way that we can exchange information. So, but it's so important right now because of policy changes that an act called the 21st Century Cures Act basically requires the use of FHIR as the rules from the act have been implemented, both at the Office of the National Coordinator for Health IT, as well as in CMS, the payers. It also, 21st Century Cures not only names FHIR, but also asks for the data in our EHRs to be better structured, and that we've seen that lots of places. And I'll give one example of that briefly, where we've been working on dealing with understanding how we can take advantage of that for pragmatic trials through the eCare plan. And then I'll give an example of some of our ways that we scale innovation. FHIR really helped overcome some limitations we had for meaningful use for EHRs. Everybody adopted EHRs, but the way the information was stored and able to be retrieved was very different. And this 21st Century Cures Act is intended to address this issue. HL7, who developed the FHIR standard, has been really focused very hard on developing use cases. So to make this learning health system capabilities easier, from evidence-based medicine to developing ways to encode clinical practice guidelines, to develop ways to get the clinical decision support in and out of clinical care through clinical decision support hooks, or CDS hooks. And for measurement, that now FHIR is expected to be the way that we report our quality measures starting probably in 2024 or 25, but in the next couple of years. So it's driving so much. And at OHSU, we've been getting more and more requests for these applications, including from clinical vendors. So for us, because of the rules that we're expected to use FHIR, we've really been thinking we need to be on top of this, but how can we make this work? Because FHIR is a relatively new standard. There's many other issues about how you do this. You can actually see clinical applications here are strapping the research applications as well. And with a problem with FHIR, and I like this picture of Elton John from this biopic that was done, health data in EHRs is so messy, as you know, that we really have to address this data adequacy issue from the start. As well, the data is not stored in the same place, so we need to figure out a way to get our data to be more accurate, complete from different places. So what are we doing about this at OHSU? Well, first, we have, through an optional function, additional component, we've started this FHIR starter capability, where we're trying to use some standard tools and some non-standard tools to build capabilities into REDCap, which is a survey tool where you can extract data directly from your EHR, either through queries or by directly assigning patients to projects in REDCap. But we're trying to build more standard ways to do that, as well as we're building augmented clinical trial, pragmatic trial support through the Vulcan FHIR accelerator that focuses on research. And that is more to come, but we're really enhancing our normal services with these capabilities. So why is the data sort of inadequate, right? So a lot of outcomes for our trials, even process or kind of downstream outcomes are stored as uncoded, or they're hard to access. They're in flow sheets or other things. How do we address that? Or they're in different places. So one way we're doing that is by tapping into templates of standard ways to do things. So if you want to collect patient-reported outcomes or standard scales, now with different resources like LHC forms, you can do that. So if you have a study that's focused on traumatic brain injury and you want to capture social determinants of health data, many of these patients with traumatic brain injury have significant issues like houselessness. We can embed the survey prepare directly coded into our REDCap form. So that's one way to do this. If you want to build symptom scales, you don't have to hand enter them. You can sort of embed them as templates into your FHIR application and have it exchange the data in concrete ways. And then also, we've had this problem where even simple things like lab values are stored in different ways. There's like very similar versions of hemoglobin A1C that are important to the lab, but not important to clinicians. And NIH's All of Us program helps us to understand what all those codes might be and really make sure we're getting the majority of them. So that's sort of our effort there. So dealing with data adequacy is the first thing. The second thing is how do you understand and apply these into trials? And so one way we're looking at this is through this broad effort called the eCare plan, where you can define specific components of studies or patient needs. So you can build a plan definition that's intended to code all the data related to something like chronic kidney disease, and then the eCare plan tries to bring that all together in sort of a series of screens that people can use. And so what we're doing with this, and it's downloadable open source, is we're trying to understand, can we use this to drive better care coordination? And then can we run especially sort of behavioral trials off this tool by predefining the data that's frequently needed for these conditions, and bringing together that data into an application that can be easily modified for these trials. So the other thing that eCare plan can help solve is FHIR endpoints are required to be public. And so if we focus our pragmatic trials more directly on the patient, patients have to be able to get access to their data without extra effort through FHIR. And so we are building under a contract from AHRQ a way to hit the different endpoints here shown at the left with the patient's permission, and to bring all that data into a research data store so that we can use our standard definitions for what data is needed to drive knowledge or process recommendations, to prioritize that and display that from multiple different sources, which is a huge barrier right now for many of our studies that deal with complex conditions. So, for instance, we don't get all our ED visits, so we don't know when people are going to other places for exacerbations from our treatments, for instance. And we're working on ways to do that. The final example before we move to questions is the COACH trial. So this is a pragmatic trial we are currently running, and I think it sort of encapsulates the example of why we think this is such a powerful tool. So the COACH is collaboration-oriented application for controlling high blood pressure, COACH. This AHRQ-funded effort is intended to show whether we can build tools and run trials that make this work. And what COACH does is for the high blood pressure or hypertension guidelines, it encodes all those into standardized recommendations, and then through a series of initial studies tries to understand the best way to show these to patients who have high blood pressure and get them to interact with the system so that they can lower their blood pressure. It's particularly good for this kind of approach because so much is behavioral. So lifestyle and behavioral changes can drive your blood pressure down and really demonstrate that it's successful, as well as many people have uncontrolled high blood pressure, in part because there's a lot of expectations on the patients to monitor blood pressure at home. And so this is a screen from our current workflow for the system. And it is an in-basket message that I get for every patient I assign to home blood pressure, where we're trying to improve their blood pressure without causing harm, because you can lower blood pressure. And what I get is every week an email about their blood pressures, and that includes if they haven't taken any. So if you look at this picture carefully, you can see, oh, most of them say no new results, but one says new results. And so the workflow for this was particularly challenging. So it was an amazing way to address it, as well as the engagement of this home blood pressure monitoring as required by guidelines was really low. So we basically are using Coach. So Coach is built in the OHSU system, but we're building a pragmatic trial for it. And we're using very standard tools to, same as eCare Plan, to basically have plan definitions for the recommendations and generate knowledge cards back to the eCare Plan, but then we filter that to be appropriate for the patient or the care team. We pull all the data in, but that's available from the FHIR server, but we also can have patient entered data, such as home blood pressures, that then can be exchanged back. And so this is really, I think, a nice example. We're able to, in our app, set two different intervention levels. One has more frequent recommendations with more effective language, which means that it's intended to drive an emotional response. Things like social norms, or what other people would do, or what your favorite PCP would recommend, versus more generic examples that are intended to be less obtrusive but equally helpful. Are sort of our question of the best way to do this and drive engagement. And the other thing we can do in the app that's really hard to do if you try and bed in pragmatic trial is we can adjust for data inadequacy. We found, for instance, in a study here, that things like goals and preferences just aren't recorded, as probably you know, as well as non-pharmacologic intervention like counseling or education just weren't recorded. Like no instances of them in some cases. And when we ran our recommendations to set up the app, we found that we had to change so many of them based on the local coding and use of the EHR to manage high blood pressure. For example, we found in 65% of patients did not have hypertension on their problem list or diagnosed, but were treated for hypertension for a particular alert. So we would have been wrong in 2/3 of the cases. So I think that's such an important aspect that we are able to address. We can also rapid cycle test displays. So we actually build our displays, and we can add text, we can add prioritization like this exclamation point. We can also say 80% of people recommend this, and then we can ask people about the trustworthiness or their likelihood to take action on it. And we found the B recommendation here didn't vary in their perceived likelihood to take action, but did vary on their trustworthiness, especially when you added the sort of 9 out of 10 dentists agree that this is the best way to do it. So, that really facilitates a kind of innovation that's hard in our other systems. So how are we managing FHIR to get back to this? It's a cross-mission effort where we're basically trying to move requests to either information blocking, because there's some thought that FHIR will be demanded by these rules, or is it a research, innovation, and quality improvement pathway? And we treat them all in that pathway, try and really talk about the value to the institution and use that to drive our prioritization. Obviously, if it's a research grant that's funded, that helps because the cost is much lower than a vendor application, but we're trying to use it as a way to think about innovation. So that's a brief overview, just sort of highlighting a little bit of shared governance and then using a catalyst like FIRE and informatics to drive improvement in the learning health system, even when you don't have a center or an approach, and really trying to figure out how we can overcome some challenges in innovation, which is our biggest issue, and openly discuss that. So that is all I have. So I know we're a little bit longer than I'd hoped, but I think we should still have time for questions. This is my wife and one of my daughters, and one of the things you can do to lower your blood pressure is spend more time in nature. This effort showed that, this study shows that you can lower your systolic blood pressure significantly during forest therapy. So I'll end on that.
Thank you, Dr. Dorr. I totally agree with that sentiment. More time outdoors is wonderful. Yes, we have plenty of time left for questions. So if attendees would like, they can either raise their hand and we'll unmute you, or you can put your questions into the Zoom Q&A. I don't know if there's, I'm not seeing any at present. Oh, here we go. First one. From Steve Johnson, thank you for the excellent presentation. I'm especially interested in learning more about how you've engaged patients to help gather their records and information in your research repository. Do you use some automated ways to retrieve data from other healthcare institutions?
You're on mute, David.
Yep.
Yes, there's a couple ways. This is a struggle, but let me go back to sort of what our plan is for this. FIRE creates the ability to, so our model for this right now, like we've worked in a number of federated learning approaches here. We use Odyssey OMOP to like get big studies together for observational studies, and then what you do is you apply the observational study logic and program to your own data, but it's all kept separate, right? And then we've worked in some enclaves, like NIH has been sponsoring one of the COVID-related efforts by having people submit all their data into an enclave called N3C. And then people can go in and analyze it. So some of our investigators have done that, but it doesn't solve this problem where we need the data more at the point of care. And we need to drive logic off that data, right? So the data has to be structured. And so the way we're approaching this now, it's not totally solved. In fact, one of the odd parts is that Epic has a system called Care Everywhere that they run that does some of this, but it doesn't actually bring the data in a structured way without reconciliation by the individual providers or care team. And that for us didn't work. People don't do that because they're busy doing other things. So what we are building in this project is basically asking the patient to log into their different systems or getting permission from these other systems with the same kind of patient consent. And then we are building connections to those different published FIRE endpoints, and then asking the eCare plan to send the same queries for the data to the different endpoints. So that means that they get a connection to the data, they ask for the same data on this patient who is given explicit permission or has asked for the data themselves. And then we store that using a very standardized tool called the GPA Happy FIRE server into a research data store. What happens when you do this is if you don't have sort of the intermediate middle layer step, is you just get a lot of junk, like so much data, you don't know where it came from. It's not all very useful. But we hope that this system will sort of address that gap to make it much easier. So this is sort of the promise of this e-care plan effort, but also I think a really nice model for people to look at to start extracting data from multiple different systems, and maybe elsewhere people have done it differently. I'd love to hear about that, but that is our sort of key way that we're thinking about this right now, if that makes sense.
Yes, Genevieve.
Thanks so much for your presentation. Really, really enjoyed it. Really curious about the workforce, how that's been built up at OHSU, and any advice you'd have around that. Because I think in many cases, well, maybe it's a question. This type of workforce may be hard to find that has the sets of skills around whether it's the standards or API-based frameworks.
Yeah, that is a major problem, actually, that we've struggled with a little bit. So one thing that's happened so FHIR is API based, of course, and so people who know how to interact with those APIs and build applications around them and have secure, work with the different EHR systems and how they manage the API are pretty rare. So we have two sort of workforce components. So one is we have an interoperability team within the EHR, just because we get so many demands for data. And they became overwhelmed with the number of FHIR applications. And so we are in the process of getting a strategic program manager, basically just to manage sort of the process and the prioritization and the different aspects, some of the technical aspects of requests for FHIR, and especially one trend we've seen is companies come to us saying, oh, we use AI and we have FHIR and we can, solve so many problems for you in this particular domain. And it's very hard for the clinicians to understand what, is there something there, or is it not feasible, or what they promise, is it not exactly able to do? And so we need some people who are really good at understanding even the standard part of it. Will that data likely be able to come, and how can that work in our system, and is this the right thing to do? So strategic program manager for interoperability is one component. We also have an Epic for Research team that facilitates our ability to build the hooks, to build in the different connections to FHIR for the different programs. And we've built some places where, we have a research and innovations apps part in our EHR, so you can find the links easily in my chart. We're building the same thing. But then developers is a huge problem. So most of the country, especially as we move to clinical quality measures, definitions being prepared to be sent by FHIR, so getting them standardized in clinical quality language. The same people are asked to do the work again and again and again. So they're very busy and doing very well, but building that local expertise is a big question. So we've ended up with 2 developers across the system who we've moved along with FHIR and keep up with FHIR, and that seems to be about right, to have that level of expectation. But I think it's a real question of how much you develop internally versus really hire out, and we've done a mix overall. So that's really the 2 main areas, and the FHIR certification is really time consuming. Our developer, one of them, spent, I don't know, 6 months or something part-time working on their certification, despite being a very capable developer. So there's a lot to learn. And, I think the question is, should we start moving more of this API data exchange into our curricula so people can at least understand how it works?
Hey, any final questions? It's seeming like that's it. So I want to thank you again, Dr. Dorr, for taking the time to present at the Class Impact Seminar today. And thank you everyone for attending. In closing, remember that our next seminar is Tuesday, December 6th at noon Central Time, and we will be joined by Dr. Rohit Ramaswamy. So this concludes our presentation for today, and we'll see you next time. Thank you.